Great to be here. Apologize in advance if there's some typos on some of these slides. I was supposed to run to pick up my thumb drive, but just got out of the hospital. So I'm one of the interventional radiologists with the Mountain Medical Group. We cover the Steward hospitals here, soon to be HCA after, if it goes through after the buyout of the hospitals went. But cover Davis Hospital, Steward, the Salt Lake Regional, Steward, the Jordan Valley, West, Maine, and 2 imaging centers that are also owned by Steward. We mostly have a hospital-based practice with a growing, best way to put it, outpatient practice, some of it being prostate artery embolization, which is what I'm going to be talking about today. I'm mostly focusing on the clinical data that's really just starting to come out in the past 10 years, and we'll touch a little bit on everything regarding the clinical side and what data is available to justify kind of treatment these days. So financial disclosures, I have none. PAE, as prostate artery embolization is short for, doesn't really have any special devices or anything like that. You typically can do it with any sort of favorite catheter and guide wire. Most of this presentation is based upon the most recent position statement from the Society of Interventional Radiology, JVIR, the Journal for Vascular and Interventional Radiology, is probably the most prestigious in our field, though the impact factor, relative to other things, are still relatively low. So if anyone's interested on more information that I'm presenting, please feel free to email me. Again, that's Sentome at Mountain Medical. I can direct you to this. But this is based upon their most recent publication in 2019. What's interesting to note is, let me see if I can get this thing going, just the endorsements are mostly interventional societies in Europe and in Asia. It hasn't been endorsed yet by any of the surgical societies. Any urologists in the room or retired urologists? No? Okay, I was going to apologize in advance. Some of this can be a little contentious to urologists, but to outline, I'm going to touch base very quickly what prostate artery embolization is all about, how the procedure is done, a little bit about who we're treating, patients with BPH, benign prostatic hyperplasia, the metrics we use to quantify treatment success and who are candidates, the efficacy in randomized trials. This is a typo. There are no controls out there. There likely won't be any randomized controls because that would require a sham prostate artery embolization or a sham TURP, which in the United States or Europe would be very hard to convince anyone to do. But it's mostly randomized trials comparing prostate artery embolization versus standard treatment, which is TURP out there. And a little bit about what the American Urological Association and Society of Interventional Radiology currently stand on prostate artery embolization, which is where some of the controversy arises from. So a little bit about prostate artery embolization, very, very superficial overview. The prostate resides just below the bladder, and you have the prostatic urethra, which is a portion of the urethra made out with the prostatic wall itself. What the goal is and what the theory behind it was initially was if you can embolize the prostatic artery, which is the dominant artery to the prostatic stroma. Sometimes some people have a capsular branch. You don't want to really focus on the periphery, but if we can focus on the arteries of the central prostate and diminish blood flow, not to make it ischemic, but to make it suffer some arterial insufficiency, we could treat the principal cause of BPH, prostatic hyperplasia, shrink the size of the prostate and relieve some of that pressure mechanical effect that causes lower urinary tract symptoms associated with BPH. The concept, again, very easy. Superficially, we're just getting a catheter distally within the prostate, focusing on more of those prostatic branches that are treating the central aspect of the prostate and then embolizing it. We do this with microspheres, which are permanent polymers, targeting the arterioles rather than the capillary bed, again, to prevent necrosis and ischemia. This is an angiographic image of a prostatic artery angiogram from Dr. Shivank Bhatia. He's the chair at the University of Miami, probably the individual in the United States who has done most of these so far in the country, and just a typical appearance of what the prostatic hemiblush looks like. And again, that kind of blush that we see of the prostate is the stromal, and you want to differentiate that from capsular prostatic branches. How it's done. The technical challenge with prostate artery embolization is identification of the prostate artery and the technical challenge of actually cannulating it with a microcatheter. The prostatic artery is very small. Depending upon the size of the prostate, it can be minuscule to something quite large if you have a humongous prostate over 100 grams. But it has quite an anatomic variance in terms of what its origin is. It always comes off the anterior division of the hypogastric, the internal iliac artery. The most common origin is off the vesical artery, typically the inferior vesicle, but also sometimes off the superior vesicle. But you see, direct branches off the anterior division, sometimes branches off the pudendal, sometimes off the rectal, and other times off the hypogastric as well. Excuse me, yeah, sometimes off the direct hypogastric. And the obturator artery that has this kind of very typical Y-shaped appearance when you look at it on angiogram can be a direct branch of that as well. Now, it's all easy to kind of make sense of things when you have a diagram, but in best case scenario, this was kind of the best image I've ever seen of a angiogram of the anterior division of the internal iliac artery, demonstrating how things kind of look when you have a ipsilateral oblique. When we're focusing on the left or right prostate, we typically bring the II to about a 45-degree ipsilateral angle to the side that we're working on to splay out the branches. You can always see this obturator artery with its inverse Y. It's kind of easy to identify, but everything else becomes a little tricky. This image kind of mirrors, because it was from the same article that I took this diagram from, so they found one to kind of image from. But what I really wanted to show was, a typical angiogram elucidates the primary, secondary, and to a small degree the tertiary branches, and the prostatic artery is almost always a tertiary quaternary branch. And so from this alone, you have multiple candidates that you then have to investigate individually to see if it's truly the prostatic artery. Here's the vesicle. You have the superior, inferior division. You can have this little guy as the prostatic artery. Typically, we have the Foley catheter in place just to elucidate where the prostate should sit. You can see little branches off the obturator that are also going in this region. Middle rectal demonstrated here, pudendal, and elsewhere. So it can be technically quite challenging. If you're an extremely experienced operator, possibly you can do the procedure in about an hour, hour and a half. Typically for people who just have 30 cases under the belt, it still takes about 3 hours to do. Once you cannulate the prostatic artery, you're using microparticles. The favored size these days in the literature is turning out to be 300 to 500 microns, which is the sweet spot. You go smaller than that, the particles end up in the capillary bed, end up causing some sort of prostatic necrosis that can cause more pain, more complication, and doesn't increase efficacy. You go too large, you don't get distal enough to actually cause arterial insufficiency of the prostate and reduce size. So 300 to 500 now in the literature seems to be the sweet spot for maximizing efficacy and minimizing complications. Most of the complications come from non-target embolization. And why is that? Well, the prostatic artery, while itself can be variable, can also have branches off of it. These include branches that end up being directed towards the rectum and the rectal anal verge, as well as the penis. If particles end up in these branches, you can theoretically cause necrosis to the rectum and penis. I've seen practitioners accidentally embolize the penile branch, and it's not pretty. You end up with penile ulcers. Rectal branches have happened as frequently that I've seen in my old practice, not my current practice, but with my colleagues doing these procedures. And I've never seen a case where you've actually had rectal ischemia requiring surgery, but it can cause proctitis and inflammation with bloody bowel movements. And these are often coiled, if you do see them, to redirect the blood flow to the prostate artery, where you can ensure a vast majority of those the particles end up in the prostate and not somewhere else. The main benefit that drove a lot of this is the ease of the procedure once it's successfully done. It's done as an outpatient. There's minimal post-recovery. And again, complications are mainly secondary to non-target embolization. All the patients that I have done a prostate artery embolization on have been able to return to work the very next day. So a little bit about BPH and what we're doing. So 40% of men over the age of 60, suffer from some severity of BPH. They cause lower urinary tract symptoms resulting from outlet obstruction, and that includes nocturia, frequency, hesitation, all that like. Medical therapy is first line. You have Flomax, that is an alpha blocker, relaxes the smooth muscles of the prostatic urethra, the bladder, and alpha reductase inhibitors like finasteride, which is the most prominent, blocking the production of dihydrotestosterone, which is the version of testosterone that acts upon the prostate and is felt to induce prostatic growth. This is a schematic of what the prostatic parenchyma actually looks like, and there's multiple zones. The principal zones that we're focusing on to identify prostatic blush, to make sure we're in an appropriate artery to treat, is really seeing blush within the central zone or within the fibromuscular stroma. Incidentally, the peripheral zone is where you have the majority of your prostate cancers arising. That does get embolized when you do a prostatic artery embolization, but has little effect on the prostate adjacent to the prostatic urethra, and theoretically little effect on treatment efficacy. Surgical therapy, TURP, is the mainstay for the vast majority of patients with lower urinary tract symptoms. TURP applies well for prostates that are relatively small, 80 grams or lower, 2 to 3 day hospital course. The problem with TURP is a lot of complications that arise. I don't know if anyone here has had one or friends that have had it. Urinary incontinence, voiding dysfunction, problems with ejaculation and so forth. Larger the prostate is, the harder it is to have a TURP that goes successful without major complications, and now you're in prostatectomy realm. So anything about 80 grams, sometimes go in for simple prostatectomy. That's 3 to 5 day hospital course. You need indwelling Foley for some time after that, and incontinence, ED, a major issue because the nerves that innervate the penis that plexus goes right along that prostatic capsule, and it's very, very difficult for surgeons to dissect it away. So often they're taking out that whole nervous system that controls continence and so forth. So the problems with prostatectomy start increasing rapidly the more invasive you become. So how do we quantify BPH? Well, there's an international scoring system, IPSS, International Prostate Symptom Score, that looks at, asking basic questions. How frequent are some of the lower urinary tract symptoms arising, urgency, nocturia, and so forth? The main thing here is the score. The higher it is, the more severe it is, and people tend to categorize 20 plus, it's a score out of 35, 20 plus is severe, 8 to 19 moderate, and 1 to 7 being mild. And ultimately, you also give people a quality of life, very subjective question. How is this making you feel? In terms of your overall quality, displeased all the way up to terrible. And different inclusion criteria for, studies that include who should receive treatment, sometimes revolve around quality of life, regardless of what your IPSS score is, because if your quality of life is terrible and it's from lower urinary tract symptoms, even if your score is mild, it's the quality of life that matters. But that can confound some of the metrics of efficacy because, we're really just looking at reduction in IPSS score to compare the two. A little bit about bladder dysfunction. This is another big confounder for anyone who is being evaluated for the treatment of lower urinary tract symptoms. If you have a neurogenic bladder or a dysfunctional bladder, you're going to have symptoms that mimic bladder outlet obstruction. And so treating the prostate or getting a TURP will have no effect on you. And so everyone who typically undergoes a TURP should have, urodynamics performed that measure urine flow rate, volume, peaks, and so forth. And these are some of the metrics that we use as well to evaluate for efficacy post-treatment. Bladder dysfunction can affect these in a very similar ways to bladder outlet obstruction. And just for reference, normal flow is about 12 milliliters a second in men. It's higher in women, of course, shorter length of the urethra. And this is some of the metrics that we'll go over with in a little bit. So prostate artery embolization, it really started taking off in the United States in the late 2009 into 2010. 11 years ago, doing a PubMed literature search, you only would find 2 studies in PubMed. That's how foreign it was in terms of literature backing up it as an actual viable treatment. And these were the 2 pioneers of it. And Carnevale is a Brazilian interventional radiologist doing most of his work prior, up in the early 2000s in Brazil. Pisco was a pretty famous Portuguese interventional radiologist who recently passed, unfortunately. But Carnevale published the first literature showing, efficacy case series and stuff like that in 2010, and Pisco followed thereafter. CVIR is the European equivalent of JVIR. A lot has happened since then. So in the past 10 years, you now have over 280 articles, cohorts, case series, so forth, looking at efficacy of prostate artery embolization, as well as quantifying symptoms, score reduction, and so forth, with about 230, the vast majority of this occurring in the past 3 years at this point. So very exponential growth in the published literature that's driving a lot of different recommendations from the IR side of, if prostate artery embolization is a viable treatment alternative. If you look at all these 280 articles, that's inclusive of 2,200 patients. Longest duration of follow-up of some of these studies are up to 6.5 years at this point. So we're starting to finally build a comprehensive sense in the literature to justify prostate artery embolization. This includes 3 randomized trials. Again, they're not control. There's 3 non-randomized, the vast majority cohort, and 6 6 meta-analysis, with the rest being, case series, independent location, experience series, and so forth. The comparative trials, I'll have 3 of them. They're randomized. I'm going to go a little bit over what their data shows. They're all randomizing patients to prostate artery embolization versus TURP. In this one, that was by Gao and his colleagues, it looked at that was published in 2014. There was 114 patients. Prostate volume inclusion criteria had to be below 100 cc's. This is important because I'll touch on this a little bit at the end. Prostate artery embolization seems to work better for patients who have large prostates. Prostate artery is larger, so it's easier to do, and you can have a more successful technical outcome. And one of the confounders is the techniques of prostate artery embolization have changed a lot in the past 10 years. In, I would say, 2013 and before, people would consider ipsilateral embolization, so just being able to cannulate one side as a technical success and including it. Of course, logic has it, if you're embolizing both sides, you're going to have more of an effect than embolizing just one. So these patients were followed up for 24 months. In general, you looked at how IPSS scores went down over that time frame, and TURP had better functional outcomes in the first 3 months, while all outcomes were fairly equivalent in 12 to 24 months, again. So just the significance of what we're saying here. TURP, mainstay of treatment for a huge volume of patients, Americans who suffer from BPH. This is a treatment modality that's minimally invasive that came on the scene within the past 10 years with this study showing that if you look 2 years out, your reduction of symptoms, the metrics that we're quantifying, are basically the same. So you have the same efficacy 2 years out. Now, it makes sense that TURP works a lot quicker. You're basically coring out that prostatic urethra, while the prostate itself has to shrink gradually and be reabsorbed. So I typically tell patients they're going to see about 80% of their symptom relief 3 to 6 months, and then you have a little bit more going out to 1 to 2 years. But it's a slow, gradual reduction in symptoms versus TURP. But again, I think the significance of this can't be understated just by the volume of patients that are receiving TURP nowadays. Another comparative trial, instead of kind of putting convoluted data out there, I kind of made my own graphs showing, not in this case, it's a little bit in reverse. The higher score is better. This was a mean reduction, so they're checking IPSS before and after. What they were quantifying here was IPSS point improvement. So this was published in the Journal of CVIR, which again, European journal, by Carnevale, one of the pioneers, and elucidates a little bit about how the techniques of prostate embolization were changing. He defined 3 treatment groups here that were randomized. The TURP versus a specialized prostate artery embolization technique versus a generic embolization technique. The generic included patients that were just ipsilateral treatment, while the specialized had to be bilateral, and he did a little mixture with his embolic beads, getting a little bit more distal with a smaller size and then going more proximal with a slightly larger size, which is his kind of trademark technique nowadays that he goes by. But again, these patients were followed up for 1 year. They included prostate volumes from 30 to 90 cc's. Again, anything above 80, 90, you're basically bringing them to prostatectomy realm, so you're not really have much of a patient population to compare to. But as you can see, are almost identical 1 year out improvement scores. While the generic prostate artery embolization, which includes confounders like only unilateral embolization, has less, but that's where the data is at if you look at the specialized technique, which is now kind of the generic technique that most practitioners use. The quality of life improvement scores were better in the TURP group, but that's a little bit more subjective and hard to quantify. Again, that's this question here. How, if you put, just saying, how are your symptoms making your life feel? And they say, anywhere from delighted to terrible in terms of how they're doing. So mostly just going by the IPSS that are purely easier to quantify. How many times are you waking up at night to urinate? 1, 2, 3, 4, and that gives you a score. The last randomized trial was published in the British Medical Journal. It's also the most recent one. And again, it randomized patients to prostate artery embolization versus TURP. It shows a little bit of the differences that can occur when even in the best attempted randomized trials. The prostate volumes here were a little bit on the smaller side, 25 to 80 cc's. Some of the data now is suggesting that prostate artery embolization is better for larger prostates, so this can confound a little bit. Prostates versus TURP. TURP is easier with the smaller prostate you go. This was another graph that I made just to elucidate the point. This shows the max IPSS. So everyone was randomized, meaning their initial IPSS was roughly equivalent, but the max is 35 if you're at the worst you can be. And what it did, it measured outcomes of where do these IPSS scores fall again in the time frame of the study, and TURP was slightly worse than prostate artery embolization. So your IPSS score at the end of this trial was around 11 for TURP, but below 10 for 9. So this is suggesting that the efficacy of prostate artery embolization was even a little bit higher than the TURP because it brought down that score a little bit more. In all of these studies, TURP was associated with more major complications and more minor complications. In none of these studies did prostate artery embolization have a major complication, and adverse events, focusing on the minor stuff, were 3 times as many or more likely in the TURP outcome, especially in the most recent one compared to prostate artery embolization. The last major study that was done was a UK registry that looked at PAE versus TURP, and this wasn't randomized, so prostate artery here tend to be younger and smaller prostate volumes. It was a 1-year follow-up. 2-day hospital stays for TURP, 0 for prostate artery embolization because they were all outpatients. This says the median normal return to activities was 5 days for prostate artery, 14 for TURP. It's variable. Again, most of my patients I advised to return to work the next day. And here the TURP was actually a little bit, both had significant improvement in their IPSS scores and outcomes, though TURP was a little bit better. And looking at peak flow, not necessarily a metric that helps quantify how much change occurs in the prostate with treatment. The peak flow ends up being much higher in the TURP than the prostate artery embolization, but once you're above a certain threshold, whether it affects your IPSS score, quality of life is questionable. So that is, again, something else that's a little bit of a confounder. But here the TURP had slightly better, both were significantly improved, though TURP had slightly better outcomes. Again, part of this thought nowadays that the smaller the prostate, the less great of an effect you're going to have than if you're treating a large prostate with prostate artery embolization. In general, you have about a 30 to 50% reduction in prostate volume. So just in pure, quantity, that's a larger volume reduction the larger prostate you have. So trends that we're seeing in the data, there's similar long-term subjective improvements in terms of quality of life score and non-subjective quantifiable metrics such as IPSS when you compare TURP versus prostate artery embolization. The TURP treatments tend to be quicker in terms of inducing the efficacy, mostly because you're shelling out the prostatic urethra, and so it makes sense, immediately after TURP, that's no longer there to restrict, while the prostate has to slowly shrink in size. Prostate artery embolization, however, has vastly lower complication rates, faster recovery, and there are much higher medical costs associated with TURP. On the flip side, that's hidden in some of this data that's being published. I'm just alluding to here, and again, if you want more info, I can send you via email, but prostate artery is suggesting it may actually improve sexual function in men, with the theory being that, the penile branch can sometimes be a direct branch off the prostatic artery or vice versa, but they're all off the anterior division, and when you're embolizing a very large prostate that's sucking a lot of that blood flow from the anterior division, you occlude it, increase the resistance there, and basically shunt and redirect blood to the gonads or other parts of the pelvis. And so in the data, there's a statistically significant increase in your SHIM score, which is sexual health that's used to quantify ED and the like. And it's kind of in line with some of the thoughts for treatment of ED, which is kind of do an atherectomy type of some of the penile arteries. Outstanding issues, anyone can blame any sort of study as not being adequate, having too many problems to it. It's still hard to stratify patients. In the randomized studies, everyone was being randomed to one or the other independent of prostate volume. Nowadays, it's very hard to do that because there's a sense that patients benefit more from prostate artery embolization when it's larger prostates, and those tend to be the ones that the urologists actually don't want anything to do with because it's more of a surgical issue. And the techniques have evolved a lot in prostate artery embolization, as I was mentioning. So the Society of Interventional Radiology at present has a very different position on prostate artery embolization than the American Urological Association, and it's causing a little bit of an uproar among interventional radiologists. But with regards to PAE, the SIR feels it's an acceptable minimally invasive treatment option for appropriately selected men with BPH and moderate to severe lower urinary tract symptoms as based on the IPSS score. They feel the level of evidence is B, with being strength strong. You know, PAE can be considered in patients with hematuria of prostatic artery. I've seen people do prostate artery embolizations just randomly when they're embolizing the vesical artery because it's a branch of it for hematuria associated with bladder malignancies and the like. And there's some interesting studies that are being done treating prostate cancer with prostate artery embolization. One of the principal investigators at NYU is using yttrium in a modified technique of prostate artery embolization to target that peripheral zone and deliver radiotherapy to the prostate to destroy the cancer. It's mostly in animal models right now. The American Urologic Association has a very different view. Right now, PAE is not recommended for treatment of lower urinary tract symptoms or BPH outside the context of a clinical trial. While, this is just my bias here, you have aquablation, water vapor thermal therapy, transurethral microtherapy, Urolift and the like that are recommended by the UAE as basically first-line treatments for LUTS. And I would challenge anyone to say that any of these modalities have as large of a literature acumen as prostate artery embolization has nowadays. And that's it. Last thing, if anyone's interested, I forgot. Coding and final thoughts, CPT coding for PAE falls under this code 37243, vascular embolization or occlusion of tumors, organ ischemia, or infarction, and so forth. It's basically non-bleeding or trauma embolization. Medicare approves it all. There are some private insurances that you still have to call and discuss with simply because the AUA recommendation is investigational. But that's about it.